So today's session is about diabetes mellitus, and I'll be discussing about a basic idea of diabetes mellitus and also about the various preparations of insulin. So the objective today is to make you have an understanding of what is diabetes mellitus, what are the various insulin preparations, what is the aim and use of insulin therapy, the various regimens of insulin therapy, and also the adverse effects that are associated with diabetes mellitus. So basically, diabetes mellitus is a metabolic disorder which is characterized by elevated plasma glucose, and this is normally due to uh, impaired glucose homeostasis. Let's see what is the normal physiology behind diabetes mellitus and a normal physiology of glucose metabolism. So normally the glucose requirements of our body is met by glucose that is obtained from the diet. So in fasting conditions, energy requirements, energy requirements are met by fatty acid oxidation. And this doesn't work with the brain because human brain is a very fuzzy organ. It consumes only glucose. So the brain will be, the glucose requirement for the brain will be provided by the liver. And this is by breaking down glycogen and also by synthesizing glucose from fatty acids and also amino acids. So the glucose in normal conditions, glucose from the diet is utilized with the help of pancreas, and the pancreas has got both exocrine function and also endocrine function. And the endocrine pancreas is called as islets of Langerhans. And this islets, they have got 5 different types of cells: alpha, beta, delta, epsilon, and pp cells. Of this, the beta cells are the ones that secrete insulin. And the release of insulin, it is stimulated by glucose, amino acids, fatty acids, and also ketones. So the basic idea is that insulin is released by food. So when you are consuming food, it will result in CNS stimulation. So central nervous system will release norepinephrine, which will stimulate insulin release by stimulating the beta-2 receptors. And also it releases acetylcholine that also stimulates insulin release. And
Sir,
yes,
am I audible?
yes, you are audible. Hello.
Sir, I guess there's a problem with your network as your voice is not clear and your screen is stuck at one point.
Till where did we reach? Where am I stuck at? Hello.
Yes, sir. Yes, sir. Now it's fine.
Okay. Okay.
And sir, please keep. Can you keep mic close to you so that your voice is more clear?
Yeah, sure.
Yes, sir.
All right.
Now it's
All
fine.
right.
Yes, sir.
Okay. So basically, the release of insulin, it is stimulated by food. So when you are consuming food, food produces CNS stimulation. So this will result in the release of catecholamines, and this catecholamines will stimulate insulin release by stimulating the beta-2 receptors. It will also stimulate acetylcholine that also stimulates the release of insulin. And the major stimulus for insulin release is glucose that is absorbed from the diet. So this glucose is the primary stimulus for insulin release. And insulin is also released by stimulus by absorption of amino acids, ketones, and other nutrients as well. And also when you have food in your gastrointestinal tract, the gastrointestinal tract will produce some hormones which are known as incretins. So there are 2 incretins which are released from the gastrointestinal tract. One is glucagon-like peptide 1 or GLP-1, and also gastric inhibitory polypeptide, which is called as GIP. And this is also a stimulus for insulin release. So insulin is a product of transcription and translation, and insulin is not synthesized as such. Insulin is synthesized as pre-proinsulin. It is an inactive insulin. And this pre-proinsulin will be transported to the endoplasmic reticulum, where it will be converted to proinsulin. And this proinsulin will be transported to the Golgi apparatus, where it will be converted to insulin. And this formed insulin will be stored inside secretory vesicles of the beta cells of the pancreas. And what happens is that normally in these beta cells of the pancreas, there are potassium channels which will help in the movement of potassium from the intracellular to the extracellular. So when and this will result in hyperpolarization. So a hyperpolarized state will be having less amount of positive charge, especially calcium inside the cells. So that will result in reduced fusion of this secretory vesicles to the intracellular membrane. So what happens when you take glucose is that this glucose will be absorbed into the beta cells of the pancreas via a transporter called as GLUT1. And inside this beta cell, this uh, glucose will be converted to ATP. And this ATP will block this potassium channel. So this potassium will not be able to move to the extracellular. So that will result in accumulation of potassium in the intracellular. So that will result in depolarization. So when there is depolarization, there will be movement of calcium into the beta cells, and this calcium will stimulate the fusion of the secretory vesicles with that of the secretory vesicle with the intracellular membrane, and that will result in release of insulin. And I mentioned about two hormones which are known as incretins, GLP-1 and GIP. And these are hormones which are released in response to food present in the gastrointestinal tract. So GLP-1, food present in the gastrointestinal tract will release GLP-1 and gastric inhibitory peptide. So this GLP-1 and GIP have receptors in the beta cells of the pancreas, and these binding of this GLP-1 and GIP to the receptors will result in increased levels of intracellular cyclic AMP. And this cyclic AMP will inhibit the outward movement of potassium. So this will result in depolarization and result in release of insulin. So insulin produces its action by binding to its receptor, which are known as insulin receptor, and which comes under tyrosine receptor tyrosine kinase. So normally in our cells, there are transporters called as GLUT4, and this is GLUT means glucose transporter. So this glucose transporter 4 will be present in the intracellular area, and when insulin binds to the receptor, this GLUT4 will get translocated into the cell membrane. So this will result in movement of glucose from the extracellular to the intracellular. And this happens predominantly in the adipose tissue and in the skeletal muscles. And binding of insulin to these receptors will result in increased utilization of glucose by both these cells. And it also stimulates the anabolic processes in the adipose tissue and also in the skeletal muscles. So during normal conditions, there will be some amount of adipose tissue breakdown, and that will result in release of free fatty acid. So insulin will also inhibit this release of free fatty acid from the adipose tissue. So basically, insulin is anabolic. It increases the adipose tissue and reduces the adipose tissue breakdown. So in the liver, insulin has action and it stimulates the movement of glucose from the extracellular into the liver. So that will result in storage of this glucose as glycogen. So it is known as glycogenesis. And also it will prevent the breakdown of glycogen and release of glucose. It also prevents gluconeogenesis. So these actions are also prevented by insulin. So insulin is anabolic everywhere in the body. It is anabolic in the skeletal muscles, adipose tissue, and also in the liver. And in the skeletal muscles, insulin will stimulate the formation of proteins from amino acids. So it will increase muscle mass. And there are some other actions of insulin. It stimulates cell growth, it stimulates cell differentiation, and also it will increase the survival of cells. So the 50% of the insulin that is produced in our body and which is present in the secretory vesicle, they are secreted into the bloodstream at very low amounts. So this is known as the basal insulin secretion. And the rest of the 50% of insulin secretion occurs when you are taking a meal. So following a meal, insulin is released in two phases. There will be an immediate release of insulin, which occurs within 1 minute of food ingestion. And this lasts for around 10 seconds. And this is followed by a sustained release of insulin, which will act for few hours, depending upon how much glucose is present in your blood. So the first phase of insulin secretion is predominantly stimulated by glucose that is present in the diet. And the second phase of insulin secretion is stimulated by glucose and also by incretins. So diabetes mellitus, I discussed earlier, diabetes mellitus is a metabolic disorder characterized by hypoglycemia. So in diabetes mellitus, there is either reduced insulin secretion or reduced action of insulin or both. So since insulin is not working properly, what happens is that there will be increase in plasma glucose or blood glucose. So diabetes mellitus is a very common disorder, and currently we are having the second largest population of diabetes mellitus. China has got the largest population of diabetes mellitus. We are close behind. So in this session, we will be discussing about two main types of diabetes mellitus, type 1 and type 2 diabetes mellitus. So in type 1 diabetes mellitus, what happens is that the body produces autoantibodies, which will destroy the beta cells of the pancreas. So that will result in reduced insulin secretion. So there is deficiency of insulin in patients who are having type 1 diabetes mellitus. In type 2 diabetes mellitus, insulin is secreted in normal amounts or in low amounts, but the tissues are not responding to insulin. They are resistant to insulin. So this is called as insulin resistance. So when this happens, when there is reduced levels of insulin, what happens is that, or reduced action of insulin, what happens is that normally our kidneys will filter glucose and it will be present in the urine, but this will be reabsorbed by a nephron. This will be reabsorbed by our nephron. So when the plasma glucose levels goes beyond the limit, that is called as the renal threshold. When the plasma glucose goes beyond 180 milligram per deciliter, the reabsorption will not take place. So this will result in increased excretion of glucose. Since glucose is an osmotically active substance, it will draw water along with it. So more amount of glucose is excreted through the urine and water is also going along with it. So this will result in one of the symptoms of diabetes mellitus, that is polyuria. And since the person is losing a lot of water through the urine, he will also feel thirsty. So that will result in the second symptom of diabetes mellitus, that is polydipsia, increased thirst. And the person cannot utilize glucose properly. He is unable to utilize glucose properly. So this will result in stimulation of hunger center. Our body will realize that we are not getting adequate glucose, so it will stimulate the hunger center and the person will remain hungry for most of the time. So that will result in increased appetite. And I mentioned earlier that insulin is an anabolic hormone. So when insulin is low, what happens is that the person will lose weight because the anabolic effects of insulin is not, we cannot access the anabolic effects of insulin. And also we cannot utilize the glucose. So the person will lose weight very fast. So how are we going to diagnose diabetes mellitus? So a person who is having increased plasma glucose can be considered as a diabetic. So there is a criteria for that. If the person is having a fasting plasma glucose of over 126 milligram per deciliter, or if he is having a 2-hour postprandial plasma glucose of 200 milligram per deciliter, or if he is having a glycosylated hemoglobin, that is HbA1c of over 6.5, or if he is having a random plasma glucose of more than or equal to 200 milligram per deciliter, plus he is having symptoms of diabetes mellitus, then he can be considered as a diabetic. So any of these following conditions, if the person is satisfying, he can be considered as diabetic. So previously, what we used to do was we used to extract insulin from pork and also from cows. So these insulins were known as bovine insulin and porcine insulin, but they were very allergen. So currently what we do is we commercially prepare insulin by inserting the pro-insulin gene into E. coli and also Baker's yeast. So this will produce insulin and we will refine that and we will use it for human use. Is used for the management of diabetes mellitus. And insulin is primarily used for the treatment of type 1 diabetes mellitus, but it can also be used in other types of diabetes mellitus. So the basic idea of insulin therapy is to mimic the physiological insulin secretion. And commercial insulin, what we are doing, aiming at is to mimic the physiological insulin secretion. So insulin preparations, they are classified into short-acting insulins, long-acting insulins, insulin combinations, inhaled insulin, which is a recently released insulin, is a short-acting insulin, and also newer insulin preparations. So the short-acting insulins include regular insulin, insulin lispro, insulin aspart, insulin glulicin, and also inhaled insulin. So regular insulin lispro, aspart, glulicin, and inhaled insulin, they can be considered as ultra short-acting insulins. Regular insulin has got a longer duration of action. Still, it is short-acting. So about regular insulin can be administered intramuscularly, subcutaneously, and also intravenously. The most common route of administration is subcutaneous, but intravenous route is used in emergency conditions like diabetic ketoacidosis. So usually this regular insulin, it is formed with zinc. So when you are administering insulin, it will form hexamer in the subcutaneous tissue around the zinc. And after some time, this will dissociate and it will get absorbed into the systemic circulation. So the onset is 30 minutes to 60 minutes. It starts its action within 30 to 60 minutes, and it's got a duration of around 4 to 6 hours, and it is ideally given 30 minutes before the meal. So there is an advantage to this regular insulin. It is relatively cheap and it is easily available everywhere, even in the rural areas. So when you're saying the physiological insulin secretion, this would be the plasma concentration of regular insulin if you're administering regular insulin. So as you can see, the first phase of insulin release from normally from our body is not covered by regular insulin. So there is an area where there is insulin deficiency. So that can result in something called as early postprandial hyperglycemia. And if you can see that the regular insulin acts for longer duration than the physiological insulin secretion. So that will result in hypoglycemia in the late postprandial state, which is known as late postprandial hypoglycemia. So these are the disadvantages of regular insulin. So to overcome that, we have created something known as short-acting insulin analogs. So we have made modifications in the amino acid sequence of insulin so that it will be having better profile similar to the physiological insulin secretion. So insulin has got an A chain and a B chain, and in the 28th position of the B chain, there is a proline, and 29th position, there is a lysine. So if you are switching those two together, the 28th, that means that in the 28th position, if you're putting lysine, and in the 29th position, if you are putting proline, we will get insulin lispro. Since lysine and proline undergoes exchange, it is called as insulin lispro. And in the B chain, the 28th amino acid is proline. So if you are replacing it with aspartic acid, you'll get insulin aspart. And in the 29th position, there is a lysine. And if you are replacing that with glutamic acid, and in the third position, if you are replacing that with, in the third position of the B chain, we have aspartic acid. And if you are replacing it with lysine, you get insulin glulicin. Since the amino acids that are newly introduced are glutamic acid and lysine, you get insulin glulicin. So these short-acting insulins, they do not form complex in the subcutaneous tissue. They do not form hexamers. So from there, it might get directly absorbed into the systemic circulation. So these agents, they have got faster onset compared to that of regular insulin. So it has got an onset within 15 minutes, and it acts for around 4 hours, which is lower than that of regular insulin. And it is ideally given 15 minutes before meal. So when you are saying the plasma concentration after a meal, this would be the physiological insulin secretion. This would be the secretion. This would be administration of regular insulin, and this would be the administration of short-acting insulin analog. So if you see that this almost resembles the physiological insulin secretion. So there is no early postprandial hyperglycemia and no late postprandial hypoglycemia. So these agents, they are ideally given 15 minutes prior to food. So if you are taking a small meal, you can take a lower dose. If you are taking a larger meal, you can take a larger dose. It is easy, but a lot can happen in that 15 minutes. The disadvantage is that it is expensive. And very recently in 2024, our inhalation, that is Afrisa, has been approved by our DCGI. And this is available as an inhalation, and the insulin dosage is color coded. So you get a blue colored cartridge for 4 units, green colored cartridge for 8 units, and yellow colored cartridge for 12 units. So this is more rapid acting, and it has got shorter duration of action. So if this is the physiologic insulin secretion, and if this is regular insulin, this would be Afrasa, which is almost comparable to physiologic insulin secretion. So the short-acting analogs, they will act within 15 minutes. This acts within 12 minutes, and the duration lasts for around 3 hours. So this was approved in 2024. And the major drawback of this Afrisa is that it produces bronchospasm. So it cannot be used in patients who are having bronchial asthma or COPD. And it also increases the risk of lung carcinoma. It can also produce a diabetic ketoacidosis, and it can produce cardiac failure. So it is thoroughly used for better glycemic control in patients with diabetes mellitus. So these are the short-acting insulin. So there is regular insulin, which is the cheapest one. Then there is insulin Lispro, Aspart, Glulicin, and also inhaled insulin, Afresa. The long-acting insulins are NPH insulin, insulin Glargine, Detamar, Degludec, and insulin Icodec. Insulin Icodec is not yet been approved, and it is currently undergoing phase 3 clinical trials. So NPH insulin is produced by adding zinc phosphate buffer and protamine to regular insulin. So addition of these agents will make the NPH insulin solution a cloudy solution. Compared to other insulin solutions which are clear, NPH insulin is a cloudy solution. So when you are injecting NPH insulin, this insulin molecules will form complex with protamine in the subcutaneous tissue. And this protamine has to be degraded by macrophages or destroyed by macrophages for this to undergo absorption. So it will stay in the subcutaneous tissue for some time. And because of this, it has got slower onset of action, that is in 1 to 2 hours, and it has got longer duration of action, like 10 to 16 hours duration. And it is ideally given 30 minutes prior to a meal. So if this is the physiologic insulin secretion, if this is regular insulin secretion, this would be the plasma concentration of NPH insulin. So as you can see that the NPH insulin acts for longer duration of time, and it has got lower peak. Since it acts for longer duration of time, what happens is that there is a chance of development of hypoglycemia in the late postprandial state. That is a major problem with this NPH insulin. Since it is long acting, it is given twice daily. It can be given in the morning and also at night. So to reduce the drawbacks or to counteract the drawbacks of NPH insulin, we have developed long acting insulin analogs. So these are insulins which has got amino acid modifications. So if you are replacing the 21st amino acid in the A chain with glycine and adding 2 arginine at the 31st and 32nd position, you will get insulin glargine, because you are adding glycine and also adding arginine. So that becomes insulin glargine. So insulin glargine is formulated in acidic pH. So our subcutaneous tissue is in basic pH. So this will precipitate in the subcutaneous tissue, and then it will be slowly released into the systemic circulation. So it has got a slow onset from 1 hour to 4 hours, and it has got longer duration of action. It acts from 12 to 24 hours. So if this is the physiologic insulin secretion, and if this is the plasma concentration of NPH insulin following injection, this would be the plasma concentration of insulin glargine. So if you can see that the peak concentration of insulin is lower in insulin glargine. So when there is a peak, there is a higher chance of hypoglycemia. So there is minimal peak, so chances of hypoglycemia are rare. And since it is very long acting, it can be given any time of the day. And the important point you have to remember is that insulin glargine is available in acidic pH. Because most of the insulins, they are formulated in basic pH or in a neutral pH, so it cannot be combined with any other insulin. The second long-acting insulin analog would be insulin detimer. So in the 29th amino acid of the B chain, if you are adding a myristic acid, it will increase the pharmacokinetic profile of the insulin. This is called as insulin detimer. So adding this myristic acid will result in formation of bond between this insulin detimer and albumin. And this is inactive and this is slowly released from the albumin, and that will result in a very long lasting effect. So this is physiologic insulin secretion, and this is the plasma concentration of insulin glargine. This would be the plasma concentration of detimer. So if you can see that this detimer has got lower duration of action compared to that of insulin glargine. So because of that, and also it has got no peak similar to that of insulin glargine. So because of that, it is given twice daily. And it acts slowly, similar to that of insulin glargine. It has got an onset within 1 to 4 hours, and it acts for around 12 to 20 hours. And currently, the longest acting insulin analog is insulin degludec. So you're adding a 16 carbon fatty acid to the 29th lysine with the glutamic acid linker. So what happens is that because of this addition, this will form multi-hexamers in the subcutaneous tissue, and it will release insulin into the systemic circulation very slowly. So the onset is similar to that of other long-acting insulin analogs, but the duration is approximately 42 hours. So it is given once a day. And the newest insulin that is currently undergoing research is called as insulin icodec. So this is a very long-acting insulin. It has got 3 amino acid changes in amino acid. One is in the 14th position of the A chain. Second is in the 16th position of the B chain. Third is in the 25th position of the B chain. And you're adding a 20 carbon fatty acid to the 29th position. So change in amino acid sequence will reduce the degradation of this insulin, and the change in fatty acid will cause a bond formation between the insulin and albumin. So it can be given once a week. And this is, if it is released, it is going to be very revolutionary, because insulin, usually people take 2 times a day or once a day. Now you need to take it only once a week. I mean, this is currently undergoing phase 3 clinical trials. So what are the routes through which we can administer insulin? Insulin can be administered intramuscularly. The most commonly administered route is subcutaneous route. And in emergency conditions, we can use intravenous insulin, and we use short-acting insulins, especially regular insulin for this. NPH insulin can also be given intravenous. And currently, we have formulation of inhaled insulin, which is called as Afrezza, and also transdermal patch of insulin is available. So the point to remember is that insulin is never to be administered orally, because insulin is a protein. So if it is administered orally, it will be degraded by the gastrointestinal enzymes. So there is a combination of insulin that is available, which is called as pre-mixed insulin. So you are mixing a short-acting insulin and a long-acting insulin. That is 25 to 50% of the insulin preparation will be regular insulin or short-acting analog, and 50 to 75% will be a long-acting insulin, NPH insulin. So this combination is called as pre-mixed insulin. And because of the presence of short-acting insulin, it is very rapid acting. The onset of action starts within 15 to 30 minutes. And since NPH insulin is present, it acts for longer duration of time. So that will act for 16 hours. So this insulin is called as pre-mixed insulin. So there are 2 regimens by which we administer insulin. These 2 regimens are called as split mixed regime and basal bolus regime. Okay. So the split mixed regime is very simple, that you give pre-mixed insulin, that is a combination of NPH insulin and a regular insulin or a short-acting insulin 2 times a day. So this combination of pre-mixed insulin 2 times a day. And this is given in the morning and at night. So this NPH insulin in this premixed insulin will mimic physiologic insulin secretion, and the regular insulin will mimic the postprandial insulin release. Postprandial insulin release. If you are using short-acting analog, it will mimic the postprandial insulin release even more. But this postprandial insulin release will be covered only during 2 meals of the day. That is during breakfast and also night. The lunch will not, lunch postprandial uh, insulin release will not be mimicked. So there are some advantages to this. This is you need to give only 2 injections in a day. So this is convenient to the patient, and this is available everywhere, and it is cheaper. There are some disadvantages as well. You cannot modify the dose of insulin according to the size of the meal. So if you are taking a regular amount of insulin and taking a very big meal, you won't be able to have, you might have hyperglycemia. And the glycemic control achieved by the split mix regime is not very, very good. It achieves glycemic control, but compared to the basal bolus regime, this is suboptimal. And the second regime is called as basal bolus regime. So what we do in this is that we use a short-acting insulin analog before 3 major meals. Yeah. So that is in the morning, afternoon, and also during dinner. And you use a long-acting insulin analog once or twice a day. So in this basal bolus regime, what happens is that this long-acting insulin analog will mimic physiologic insulin secretion, basal insulin secretion, and the short-acting analog will mimic the postprandial insulin release of breakfast, lunch, and also dinner. So the advantage of this basal bolus regime is that it has got better glycemic control. There is a reduced risk of hypoglycemia, and you can adjust the insulin dose, the postprandial insulin dose, preprandial insulin dose, that is during the morning, lunch, and dinner, according to the size of the meal. If you're going to take a very big meal, then you can increase the dose of insulin. But that flexibility is not available with the premixed insulin. The problem with this is that it is expensive and the patient requires 4 injections per day. So that is a major disadvantage. So about the uses of insulin, insulin is used to reduce blood glucose. It is used for the treatment of diabetes mellitus. It is primarily used for the treatment of type 1 diabetes mellitus. It can also be used for uncontrolled type 2 diabetes mellitus. It is used for gestational diabetes mellitus and also for diabetic ketoacidosis. So you know that insulin reduces plasma glucose levels. So when it goes beyond, when it reduces beyond the limit, it can result in hypoglycemia. That is a major adverse effect of insulin. So insulin is anabolic. So insulin produces anabolic effect. It produces increase in adipose tissue development, and also it increases the protein synthesis. So use of insulin can result in weight gain. Another thing is that since insulin is anabolic, it can result in hypertrophy of the adipose tissue where we are injecting the insulin. So this is known as lipohypertrophy. So these are the major adverse effects of insulin. And currently we have a provision called as continuous subcutaneous insulin infusion, that is CSII. So this is a wearable device. It has got a glucose sensor. So it will sense the plasma glucose and it will release small amounts of short-acting insulin into the circulation. And this will mimic the physiologic basal insulin secretion. And based on an algorithm, and also based on the plasma glucose and the amount of insulin present in the plasma, it will give you a value of bolus doses to be administered in the morning, evening, and night. So this is a very convenient procedure, but the thing is that it is very expensive. So it reduces the risk of hypoglycemia. This thing reduces the risk of hypoglycemia, and it also provides better glycemic control. So that sums up about everything about insulin. So I have a few MCQ questions which I would like you to answer. So shall we go into it? So the first question would be insulin receptors are A. JAK-STAT receptor, receptor tyrosine kinase, G protein coupled receptors, 4 is nuclear receptors. Yeah, insulin receptors are uh, receptor tyrosine kinase. It is, they are not G protein coupled receptors, they are not JAK-STAT receptors or nuclear receptors, they are receptor tyrosine kinase. So next question, which of the following insulin preparation is most appropriate for controlling postprandial hyperglycemia due to its rapid onset and short duration of action? NPH insulin, insulin glargine, insulin degludec, and insulin lispro. So what you have to understand is that NPH for controlling postprandial hyperglycemia, we need short-acting insulin. NPH insulin, insulin glargine, insulin degludec, they are long-acting insulins. Insulin lispro is the short-acting one among these. So insulin lispro would be the ideal option. So the next question. Diabetic patients on subcutaneous insulin develops lipohypertrophy at the injection site. Which of the following best explains this phenomenon? Insulin-induced local allergic reaction due to causing fat necrosis, immune-mediated panniculitis, anabolic effect of insulin on adipocytes, fat atrophy due to lipoatrophic effects of insulin. Yeah, insulin is an anabolic hormone. It increases the growth of adipose tissue. So that is probably the reason why this person is having lipohypertrophy. Next question. Contraindication for afrisa is bronchial asthma, systemic hypertension, hemorrhoids, dyslipidemia. Yes, afrisa. What is afrisa? Afrisa is an inhaled insulin. So it produces bronchospasm. It produces bronchospasm. So it cannot be used in patients who are having bronchial asthma. Okay. So I hope that it was very clear to you. Insulin is a hormone that is secreted by beta cells of the pancreas. What insulin does is that insulin is anabolic. It will move glucose from the plasma into various tissues, mainly adipose tissue and skeletal muscles, and also liver. So that will help in better utilization of glucose. Insulin also promotes the growth of adipose tissue. It also promotes the growth of muscles. It also promotes the storage of various nutrients. That will cause type 1 diabetes mellitus. That is due to absolute deficiency of insulin. And type 2 diabetes mellitus, insulin is produced in normal amounts or reduced amounts, but it fails to act. The receptors are not responding to the insulin. The commercial preparations of insulin, they are produced by recombinant DNA technology, and this is available now. So we have two types of insulin preparation: short-acting insulin preparations and long-acting insulin preparations. The short-acting, the most commonly used one is regular insulin, and there are very short-acting ones or ultra-short-acting ones like Lispro, Aspart, Glulicin, and Afrisa. The long-acting ones are NPH insulin, which is very commonly used, and then there are long-acting analogs like insulin glargine, insulin detimer, and insulin degludec. So these agents, they are mainly used for the treatment of diabetes mellitus, mainly type 1 diabetes mellitus. And it can also be used in uncontrolled type 2 diabetes mellitus, gestational diabetes mellitus, and also diabetic ketoacidosis. So since insulin reduces the plasma glucose, administration of insulin can produce hypoglycemia. And it can also produce lipohypertrophy at the injection site. And it can also produce weight gain. So there are two regimens of insulin. One is called as the split mix regime and the basal bolus regime. So split mix regime is that you are using a combination, a pre-mixed insulin, that is a combination of short-acting insulin and a long-acting insulin. Short-acting insulin like regular insulin or insulin analog, with a long-acting insulin like NPH insulin. So it is given 2 times a day, morning and at night. And the basal bolus regime, you give a long-acting insulin once or twice a day, and you give ultra short-acting insulin analog following before every meal. So that sums it up.